social work was involved because, yeah, we could be radiation gung-ho ready to go, chemo can be ready, but oh, whoops, this patient doesn't have a ride. It could be little things like that, or we kind of forget, you know what I mean? That's why you need kind of a multidisciplinary approach, If it's not your social worker, your navigator is going to know more and be like, oh, no, this patient needs a ride. I'm working on gas cards, something like that. That can also halt, a patient starting it.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with John Hollman, Senior Nurse Manager of Radiation Oncology at AdventHealth Cancer Institute in Orlando, Florida, about the side effects and best practices for care coordination during radiation therapy. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks for joining us today, John.
Awesome. Glad to have you. Thank you very much. Glad to be here.
So to start off, big question, but let's just kind of look at the landscape, do a brief overview or some of the more common toxicities or side effects that we see from radiation therapy.
As I like to always kind of educate, we are a site-based, site-specific modality. It makes our little test questions a little easier sometimes, where we aim the machine, look at your anatomy, and this is the area of the body that we affect, and you go from there, So, like I said, again, it can range anything from simple, say breast, biggest reaction is obviously the skin. Skin reaction is a big thing in our field for breast cancer, managing it with lotions and creams and stuff like that, is temporary, to something more complicated like the head and neck cancer, patients with, base of tongue, stuff like that, where, the beam is directed straight, at that area of the body, which is very delicate, as we know, very, very, very tough treatment. Anything from esophagitis to dysphagia, dry mouth, no taste, salivary glands are affected. So it really kind of depends, obviously, where we aim the machine. So when I educate, like I said, my new nurses and stuff like that, it's just, I do a 2.5-hour PowerPoint presentation, just kind of work my way from the head down, do your neuro assessments, brain, things like that. So that's kind of, like I said, a little bit easier in our field. I don't want to, jump on anybody to say that it's easy by all means, but, you just got to kind of know where we're aiming. And yeah, you can just kind of know your anatomy and what would be affected if you're blasting this organ or tumor site with radiation, respiratory symptoms, things like that. We can pretty much stick to that, which I think will lead into, as we go with this talk, kind of how to decipher between what causes what.
That's good, sort of logic of well, where's the beam going and what structures, organs, important parts are underneath that or around that target, even though we know that many modalities in radiation now can be much more targeted, much more precise, and so much better at controlling that, but still possible and still happens. You gave some great examples. I think one that maybe isn't always as thought of is bone marrow. Are you targeting an area that is a big source of creating those new blood cells? And so that's one that maybe doesn't always, I think for me, didn't always resonate as a clear cut, oh, well, yeah, of course, that's from the radiation. So that's great advice.
I'm actually glad you brought that up because that brings me back to, and I've done this 20 years, you always think of a story once you're triggered with it. And yeah, ideally, I used to teach in the radiation therapy program for therapy students down in Texas when I was there. I did it for 6 years and I got to teach them kind of an introductory nursing course to radiation therapy. So I loved it. And one of my things was when I was telling the students, I was like, you're going to love my class, guys. As long as you know your anatomy, when we talk about side effects and the management, you just got to know, like I said, your anatomy and physiology and where we're aiming this machine, but to lead to your example, yeah, and I think radiation nurses also just kind of, because we're not lab heavy as they are in med-onc and infusion. And I think that's a different thing with radiation, but, I ran into an instance, a couple of years ago in Texas where, the med-onc reached out to me, and was like, hey, this guy's, platelets had dropped, suddenly what's the, we're going to work him up for a possible transfusion. And I said, whoa, let me look at the treatment field. And because our rad-onc was off and I pulled up the treatment fields, in our radiation system. And yeah, they were treating a large, iliac crest, or in the hip, or if it was that or mediastinum or something like that. And he was like, that makes sense. So I don't have to worry. This is all radiation effect. And I was like, yeah, it's just, things like that take you to remember, yeah, we can. It's not common unless you're treating a bone marrow producing area, but, that we can cause blood counts to sway.
So kind of along that same line, many of our patients are either, whether it's concurrent treatment where they're receiving a systemic agent, a chemotherapy or something alongside with their radiation therapy, and kind of might be sandwiched in between, kind of back and forth. But clearly both of med-onc and rad-onc, we are kind of caring for a patient simultaneously. And so depending on what treatment they received when, it can be sometimes challenging to know for sure which treatment may have necessarily been the primary culprit. Sometimes it's both, which then makes it extra complicated. But do you have any recommendations or considerations of how you approach deciphering kind of which treatment is responsible for which side effects?
Absolutely. And I'll make a joke, blame chemo. No, I'm just kidding. We always have that joke between med-onc and rad-onc. Oh, it's not us, it's them. We always like to do best practice, best nursing practice. When this come down, I'm glad we're talking about this, but in reality, it doesn't matter who causes what. We just really need to get it treated. But to answer the question, I think it really determines on how that radiation nurse knows how radiation affects the cells that we treat. So for instance, I always tell my patients when I'm educating them for head and neck, and I know they're going to be getting concurrent, cisplatin or something like that once a week, I'm going to tell them like the majority of your acute side effects are us. Like, the chemo is going to work as a sensitizer. You're going to have fluids that you're going to be needed, but the difficulty swallowing, all that stuff is our fault. It's us. So PEG tube is going to be needed, hydration, which does involve your infusion team and coordinating with them 3 days a week, sometimes longer for infusion, supplemental hydration. And I do like to kind of take that ownership. But again, you look at your GYN patients who get the cisplatin as well, but we're always focused in the pelvis, when they talk to me on your on treatment visit, once a week, that they're having some ringing in the ears, and why would radiation be causing that? I know because I've done this for a while that, that's typically tinnitus, that can be caused from, obviously your platinum-based, chemotherapy. And, please let your med-onc know, and I can shoot your med-onc nurse an email, to know because they might need to lower the dose. And again, I never like to kind of shy it away, but I do like to point out that can be the case. But I get it a lot of times on breast patients, which, they aren't concurrent, but you'll have a, breast patient that comes back for their first follow-up and they've started, your aromatase inhibitors, and they're thinking the radiation is causing their hot flashes and joint aches, and that's when you have to sit down and, put on your little education thing and be like, oh no, that is med-onc, that is your hormone therapy. And, you need to kind of discuss that with your medical oncology or APP on the next visit. But I think when it boils down to it, I think nurses need to know, and I think radiation nurses need to know chemo as well, not the ins and out like an infusion nurse, but I think I benefited from myself of taking that ONS biotherapy chemotherapy course early on in my career, just so you can kind of learn the different things that can happen during the concurrent therapies. And I think education up front, knowing how the radiation works on the cells that we treat, I think that is a great starting point to kind of decipher who's causing what. But again, the ultimate thing is who's causing what. Yeah, we just need to get it taken care of is, I think, the importance when it comes to the end of it is we need to get this taken care of if it's us or if it's them.
I really like how, yes, that's very funny. Yes, it's always chemo's fault, which, usually true, to be fair. Yeah. But I think you made an important point. Like if these agents are given at low doses as radiosensitizers and, in a different way in the med-onc realm, we have to be sure we're educating patients so that they have appropriate expectations. Chemotherapy isn't immunotherapy, isn't targeted therapy, that they shouldn't, what shouldn't they expect based on not only the kind of agent that they're receiving, but the dose and the intent of why it's being given. And so that is all a comprehensive part of that education, because I think patients assume the same thing. Oh, if I feel bad, it's my chemo's fault. And sometimes that's not true.
Well, Jaime, as a provider, we know these patients are overwhelmed. They're dealing with such a life-changing event, life-changing diagnosis. And to be honest, I really don't think when it boils down, they don't care. They just want it taken care of. So it's not the time for nurses out there to be like, oh, it's them, talk to them. It's about, this is why we're here. This is why we do our job. We're their advocates. If I can say, oh, yes, unfortunately, that is a side effect of your chemotherapy, let me help you in getting that taken care of. Let me send an email, let me call them. Also giving them some responsibility, and please at your next visit, do this. But I think, like I said, it doesn't matter if the patient thinks who causes what, but they're just there. They just want to get rid of it. They want to take care of it.
I think you also, again, pointed out when they are receiving radiation, likely, it's a daily treatment often, and they're seeing radiation much more frequently than they are seeing infusion in medical oncology at that point. So as you said, I think it is imperative that wherever you subspecialize in oncology, you have to have a baseline awareness and understanding of everywhere else that patient might go. You won't be the expert, and that's not the expectation, but knowing enough to help appropriately guide the patient, help redirect them, help connect them to the proper provider or specialty. And as you said, not just saying, well, that's not our problem, like helping address the issue for the patient in the most efficient way possible. So you're absolutely right. So kind of along those lines, we are coordinating care often between med-onc and rad-onc, sometimes in surgery, sometimes radiology, it could nuke med, it can kind of go anywhere. And so what are some of the common challenges that you have faced or you see in coordinating care for patients who are receiving these multiple treatment modalities, either sequentially or concurrently?
Oh, loaded question. Achilles heel, man. So I did an ONS magazine article on this too, the breaking down the barriers. And I don't think it's either one's fault. I think med-onc is med-onc. They have their own tons of responsibilities that they're doing. Rad-onc is rad-onc. We have our own. It's just bringing those two together. It's going to depend on what kind of facility you were in. In Texas, I was blessed. I was spoiled. We had comprehensive centers everywhere. So chemo was literally upstairs, but that's not always the case. Where I'm in now, the bigger entity, chemo most of the time is not even in the same building. They might be across campus or something like that. Or God forbid, if your med-onc is not affiliated with your rad-onc site. And that can be a horrible barrier to try to break through because you don't know anybody in that office. You identify yourself on the phone as someone from a competing company. They're going to be like, yeah, I'll send you to a voicemail, but it's just breaking through that. And it just takes that nurse's initiative and hopefully physician coordination as well to work on, rad-onc between med-onc, and getting that to kind of facilitate that. And I might get getting ahead of myself, but what I kind of found important is doing those weekly huddles between modalities, however your center can do it, or if it's just departmental. But I think that biggest barrier is just that communication. The med-onc office can be large. I sometimes never met some of the med-onc nurses that I deal with on email. It can be hard to sometimes find that point person on who to go to for these questions.
Well, I think, like you said, location and actual physical proximity. Are you a floor apart or are you at least in the same building or is it across town, across the state? Another thing I know that we've talked about on a previous episode is the electronic health record. If you can't see the same information because they have to be in different systems because one runs the machines for radiation and the other is what the whole system uses for their general medical records, that's a barrier of just not being able to clearly communicate inside that record and see the right information for both sides.
That is a great point. And I deal with that barrier now. But luckily, like I said, our med-onc and rad-onc are kind of starting to form into the same medical record other than the record and verify that we always have to have. I think a lot of surprises to med-onc teams and stuff like that is oh, you have two medical records. I'm well, yeah, we do because our machines have to have their own, medical record system, Mosaic or ARIA, whoever you're using as a record and verify for your treatments, and sometimes the nursing documentation is in the radiation medical record. Sometimes it's not, I prefer it to be on the joint record so that your med-onc and rad-onc can see what everybody's going on. I really appreciate that. So any side effects calls that, the med-onc nurse can document. And how patients do, they'll just call both offices and whoever gets back to them first, so it's always good to see, oh, you called med-onc about this 30 minutes ago. It looks like they acknowledged it. They're just waiting on an answer, but at least I can see that. But like I said, outside entities, you're kind of at the mercy of getting records faxed, which is, there is no way to break that down unless you can think of some magic internet thing in the future, But yeah, that's a good point. I'm glad you touched on that. The EMR is definitely imperative for that communication.
Absolutely. Yeah. It's 2024 and we are still faxing records. What is happening?
I say the same thing, but hey, we do what we got to do, right?
There's opportunity there for sure, but it's still sometimes if there's nothing else, that still works. So,
there are some medical records that do talk to other ones, because it's the same. You just click on a button and you have access to the records done at an outside facility, but again, that's not every center has that.
Well, and I think another thing that you mentioned, which, I think is a great tip of if you're not in the same system or in the same location as your counterpart department, med-onc or rad-onc, you do have to kind of get to know who's your point person in those office. What are the back channels? How do you get around the phone tree? Because you know who you need to get to talk to. Is it a direct email? Is it something in your portal that you can message someone? And so, a lot of systems have sort of these HIPAA compliant kind of text messaging sort of apps as well. And so just identifying, for those sites, if you work with a certain site frequently, who are your people that you can kind of get to and what are the best ways to do that? Because everyone on both sides of that patient, they want to be able to communicate clearly and efficiently and just help treat that patient as expeditiously as possible. But sometimes you have to get creative because you don't want to get shoved a voicemail.
And I think with the changing technology, like for instance, just using my place as an example, our division is so big, we could be treating at one site in Orlando and my patient's med-onc is in 30 miles away in Altamont or somewhere else, or down in Kissimmee. So that's a, long way to go. So what we've developed to try to help that, and any tips out there for any nurses, having this issue is, we communicate on Teams channels. So we literally had to sit down and be like, okay, who's the med-onc nurse for this? Who's the med-onc nurse for that? And we have Teams channels on there. And so if we have a patient in our clinic that's having problems with a different chemo side effect, my nurses know, they get right on there, they email, and I will say that has really changed our landscape of communication is Teams. And like I said, our centers, we have that. That was our primary communication is Teams. And that has worked out. Like we named the group this doctor's med-onc team, and they have our med-onc team named, and we just talk on there. And it goes off literally all day, and that's a good way to kind of help coordinate care, as well, and just dealing with these side effects on who is what, or if they need supplemental hydration. Hey guys, can you work on this and get them in, and it's really kind of been changing that for us in the better. But again, not everyone has that ability and it doesn't help with your outside providers. So what I suggest with that, I had an experience a couple of weeks ago where I was at an ONS dinner and we had a new member come in and introduced herself. And she's like, I'm the nurse for so-and-so. And I was like, hey, and I, made sure I gave her my card and I'm like, hey, we do have a lot of concurrent patients together because you don't have radiation. So you send them to us and, let's break this boundary. This is my email. Let me get your work email and just kind of any way you can inch your way into that foreign land, is I'll take it.
Well, that's great. So let's keep talking about this. So what other successful kind of examples can you share just about some other of those collaborative practices? You had mentioned huddles. Maybe talk a little bit more about that, of just how to bridge that communication gap.
Yeah. So different places I've been, over the course of 20 years, we all do something a little different, but they've all kind of really helped out. So at one place, we did a weekly in rad-onc only, a departmental, we called it chart rounds, kind of chart round / huddle. It involved someone from the front desk, social work, a dosimetrist, the physicist, the therapist, and we would all go through all of our new starts from the previous week or up until that day of chart rounds. And that's where we would identify these patients, like say we missed it in nursing that this was going to be a concurrent patient. It would be identified there. And then from there, we would take it because we had point people developed already in med-onc and be like, hey, I just had chart rounds today. I just found out Mr. So-and-so needs to get started ASAP. Where are you at? And then, did you get a port place? Stuff like that. So that is a really good way to do it departmentally. Another way that I've experienced as well is getting together and post-COVID, it's kind of our work environment has changed. So Teams is now a great tool that is utilized instead of trying to gather in person. So like where I'm at currently, it's just such a big division. So we have a point person from med-onc on a weekly Teams meeting. Each person takes turns with their provider and be like, hey, I have Miss So-and-so. This is where we're at. We're still waiting on auth, and rad-onc will chime in and be like, hey, planning's done. You just give us the go ahead and we will get them started. That kind of thing is super, super helpful as well. And again, like I say, developing that relationship with med-onc and vice versa. It's good to have that relationship. And I found, I'm not pushing ONS, but the ONS dinners, like I said, I'm lucky where we have the med-onc team come and, you get to meet them and just, if it takes just getting up there to meet them in person, face to face, like, hey, I'm the nurse for this one, anything you need, email me. And I think just sometimes that face to face is needed to kind of break open that barrier to kind of work together. And if you can have an in-person huddle, would be great. If you're in a smaller institution, that would be even better. But, departmental is great, to identify that in your department so that nurse can get to work, and I think it's a team effort, because obviously rad-onc, knows this patient's going to be concurrent. Our therapists are well trained to know I cannot give this patient a start date before we have chemo on board, because we have identified people that fall through the cracks. And those therapists are trained on that day of treatment. Like we were about to start a patient walking in the room, and that therapist, thank goodness, was like, hey, how did your chemo go? And stuff like that. And then the patient told him, oh, I haven't heard. I don't even have a port yet. And we're just like, woo, okay, let's go ahead and turn around and walk you to the nurses, So I think it's getting all involved. It's not just a nursing task in radiation. These therapists are the ones actively delivering the treatment. So if they're not involved, it can be kind of tough.
Well, and as you mentioned, I mean, those huddles, it's not even just clinical staff. It is front desk. It is support staff, dietary, social work. If they are involved in those patients, obviously a role we're seeing now more widely spread is navigator, which kind of serves as that hub. But, including any touch point the patient can interact with, if it's scheduling, if it's, if it's their nurse in the infusion, if it's a nurse in their clinic space, their therapist, as you said, like bringing everybody together to kind of hear the same update and be aware of what information needs to be shared amongst the group. I mean, there's no better way just to clearly communicate. And as you mentioned, like the sort of embracing of virtual meetings and allowing, that cuts down on the barrier of distance. So it doesn't matter that you're not in the same spot. If you know that there's a meeting you can dial into to listen in and share any concerns, like that is just a great way to get everybody on the same page for the best care for them.
Any kind of supplemental things, like you said, social work was involved because, we could be radiation gung-ho ready to go. Chemo can be ready, but, oh, whoops, this patient doesn't have a ride. It could be little things like that, or we kind of forget, you know what I mean? That's why you need kind of a multidisciplinary approach, If it's not your social worker, your navigator is going to know more and be like, oh, no, this patient needs a ride. I'm working on gas cards, something like that. That can also halt a patient starting it, it's stuff that, sometimes the clinical team, you kind of forget or you neglect and be like, oh, thank God you were here. Okay, I get it. Okay, this is what we're waiting on. What can I do to help you? And so, like I said, I think the huddles are kind of imperative to do that. And the more people involved, better.
Absolutely. And, and we see that it's sort of adjacent to like your tumor board, where that's more in the planning. And this is kind of a similar meeting structure, but it's like as you follow them through treatment, just to make sure if changes come up, if things need to take a different course based on variables that are unpredictable, then that allows the whole team to kind of stay on track together. So I think that's a great idea. So John, we're seeing rapid advancements in all areas of oncology, and radiation included. So how do you think individual nurses, the nursing team, can stay updated on these latest developments, best practices, and how can they sort of recognize and manage side effects that are associated with radiation therapy in the midst of all this?
Jaime, I'm going to seem like an ONS promoter, but I can't help it. The 20 years I've been in oncology, radiation specifically, even a little more, I think ONS is always a good source for anyone. If you get blessed to be able to go to Congress, I think that is eye-opening. It is so informative, a little overwhelming, but it is fantastic. I'm speaking there in April, by the way, too. So it's a great thing to meet and network with other oncology nurses from all over the country and most of the time, sometimes the world, So it's a great resource. I love the ONS radiation communities. We do a lot of idea sharing on communities from, a rad onc nurse from New York can post something like, hey, what are you guys doing for this side effect? We're not having any luck with this, and you get, some buy-in, and as long as the nurses remember, evidence-based practice is always key. Just because you use one lotion doesn't mean, it's going to be good for everybody. I like to see the evidence behind it. I like that, and I like the Astro resources of rtanswers.org. I love that. It's got great videos for new nurses. We use it for patient education, but to keep up to date with that, and I always kind of try to instill some pride in my nurses that we're more than just what we do. We need to know the technology of the machine, so if they're given a little machine in service, like, why do these nurses need to know that rapid arc is so good? Well, it cuts down on your treatment time, less time the patient's on the table, less pain, less area for movement. Why is that important that a nurse needs to know that? Cuts down your treatment time from the old days when I started, where IMRT was 45 minutes to an hour to now being 10 minutes. It's a huge difference in nursing, and vice versa. The therapists kind of need to have an understanding of the nursing realm as well. And, just kind of learning together. But, and I think, like I said, in a broader aspect, I think Congress would be absolutely great. ONS member, get your magazine delivered to your house. Like, there's so much education resources out there. I think obviously ONS this is why I'm so proud to be involved with this is working on more education for nurses. It's very, very hard to find. Most of our drug dinners at ONS are obviously med-onc based, infusion based, with the ever evolving radio farms that are coming out, that we're doing here too. It's, it's turning more into nurses are actually giving the treatments, So, and that's what I'm speaking on in Congress. It is the nurses' evolving role in radiation and radio farms, especially. It's a huge breakthrough. It's the future pretty much.
Well, and I like that you brought up the ONS communities. There are various communities that are, topic specific, but the biggest one is just sort of the all member community. And it's just so interesting to see what questions come up, even if it's not a question I had, just to be able to read it and hear what other people are saying and doing and just bringing that issue into my awareness so that I might see it in the future sometime or pick up some connections to other things that I'm doing. And so it is a great, just like Congress, where it brings together, nurses from all areas and all specialties to learn what maybe they wouldn't have an opportunity to learn. So in that radiation track at Congress, there's a whole series just dedicated to that topic. So you're right. I think we owe it to ourselves as oncology nurses to stay as comprehensive in our knowledge as we can, knowing that we have to, focus on what is our most common issues to deal with, but that broadening that scope of understanding other areas of our specialty is important because it ultimately will impact the patients that we care for.
100%.
Well, John, it's always a pleasure to talk to you on our podcast. As we come to the end, we'll run through a series of quick fire questions just to help summarize some of the topics that we've covered today. To kick that off, as healthcare professionals, we know it's important for us to acknowledge and evaluate our own hidden or implicit bias. What is important to consider when we're evaluating that implicit bias concerning radiation oncology?
Well, I think a good thing out there is just a misnomer. Like I said, if you're in med-onc and you've worked med-onc your entire career, you might have some basic idea of radiation and what goes on. But I've encountered many times that they think, honestly, like we're like radiology. Oh, it's just all a matter of lining up the patient on the table for a few seconds and starting the machine, And I think it's, like, no, it's a way more in depth with that. This is why we have less side effects now because of the alignment done through onboard imaging and stuff like that, which can sometimes in itself take 10 to 15 minutes, looking at bowel, looking at the bladder, if it's not full, things like that I think takes into account. And now that we're doing this, we're doing this every day, like in the old days, we were doing it maybe once a week, and the side effects were much worse because, we couldn't see inside the body and where we were targeting every day, like we can instantaneously, with the onboard imaging. But I think it's stuff like that, and I've always said, even in my last podcast, if a med-onc nurse can come down, spend some time with radiation. I know it's easier said than done. It's mind blowing. Or even if they can just watch some videos on it, just to know what goes on and vice versa. I've been guilty of being like, oh, chemo's running late again. Gosh,
what are they doing up there?
What are they doing up there? And, obviously I know better, it's ingrained in you to be like that. But I think vice versa, what's taking radiation so long? Well, the patient before this patient had an issue. It's stacked, and I think kind of just learning through that is a good way to kind of get rid of that bias and just be kind of more open that, it's not just cut and dry. We're not just laying patients on a table like an x-ray and doing it. There's a lot more safety stuff to do and alignment that's done by these brilliant radiation therapists.
So if you had to maybe pick one most common misconception about radiation side effects and care coordination, what would it be?
Well, again, they're not instantaneous. I always like to think patients are always terrified when they come for day one. I'm going to walk in, that book you gave me and we talked about the side effects. I'm going to walk out of here with all of these today. And I'm like, no. I think nurses now kind of more have a better idea, but the education needs to be said. Typically we're given that 2 to 3 week grace period of side effects to really start to emerge, and I think people forget about that sometimes. Obviously there are outliers, like a stomach, things like that can have immediate side effects within a couple hours, but it's up to that nurse to really educate that. But just to be aware that, these are slow to come on, but they're also slow to go away, when we're done. And, most of our side effects can peak in those 2 to 3 weeks when they're not even in clinic anymore. And they kind of feel their worst, when they're not coming in any day. And it's just about preparing the med-onc team for that possibility and, needing those supplemental infusions, of fluids for another 3 to 4 weeks post concurrent therapy for head and neck until they can kind of start eating and drinking a little bit on their own.
What's something about this topic that's not often discussed, but you wish people knew more about?
Like we talked about earlier, the planning that goes behind it. These dosimetrists and stuff that work behind the scenes to make this patient's treatment the safest, least toxic that can be done is mind-blowing. Like I said, I've had the ability in my career to actually follow some dosimetrists back before the pandemic when they weren't working a lot remote, but to actually sit down, and that's actually part of my onboarding with my new nurses, is having them sit down with a dosimetrist and watching them do a treatment plan. The stuff that they deal with, they work with the physicians constantly, head and neck, or say the prostate, this rectum's going to get a lot of dose if we do this. They try to do the best they can with those organs at risk to lower that toxicity. And that can sometimes med-onc doesn't understand, like, why is it taking so long for your treatment plan to get ready? And, it's not about the auth. The auth is done. It's just the treatment planning can be a problem. And I always like to remind them, it's complicated. And God forbid if they're a retreat or somewhere close to that area, those dosimetrists are working hard as they can, but they have to do it safely. It's, something unique to us that we don't really have an infusion. You know what I mean? You have the prescription, the pharmacists do their thing with the chemo, that's drugs are ready, the nurses give it. We have a whole nother specialty team that does all our treatment planning, and makes that prescription a reality.
What additional training or education do oncology nurses need to stay current on this topic?
I found this very valuable. That ONS rad therapy cert, that they have right now, that's kind of updated every couple of years. I took it about halfway through my career and I was like, what can I learn from this? And I was blown away. I was like, you take it at your own pace. It was lots of CEUs. I actually got a scholarship to take it to pay for the thing and, from ONS. And it was great. It was a great resource, like I said, to learn about, radiation stuff that I didn't know about. It goes all the way from radiobiology to, time, distance, and shielding and stuff like that, but worded more towards nurses. And I think that was invaluable.
I love it. And we recently updated that and released it, I believe, early this year. So excited to have shared that with our members and our audience so that hopefully that will be beneficial to them as well. And finally, are there any additional resources that you recommend for patients that maybe want to learn more?
Yeah, like I said, ONS is a plethora of resources. Evidence-based practice is a big deal. I don't care about the latest and greatest lotion. I want to know what's behind this. Like, do you have a study that proves that this, decreases radiation dermatitis, stuff like that. But I think, rtanswers.org, I've used, for over 10 years for patient education, for new nurses education. What I like about it is I can throw a pamphlet at a patient all day long or a new nurse, and it's the video component. There's videos, they break it down into site specific so you can watch a breast patient getting treatment. It's translated into English and Spanish, depending on what you wanted to do. They have a general radiation overview of the ins and outs. How they can get a view of the machine, because patients think it looks like an MRI, but it's not. And recently, because I have, part of my managerial task is I have a big brachytherapy department, which is the internal radiation, and American Brachytherapy Society. I just literally discovered this about a few months ago. It has a great nursing tab with nursing education videos for brachytherapy nurses. It is about 45 minutes long. It's presented by a nurse. Fantastic. Like I said, I wish I discovered it earlier. So if there's any brachytherapy nurses out there that want to learn about it, it's American Brachytherapy Society, and there's a ton of nursing resources on there.
That's amazing. Thank you so much for sharing. We'll be sure to include a link to that in our episode notes as well. Well, John, thank you again. So great to always have you on and talking about radiation. I always learn something. Do you have any final comments to share with our listeners today?
It's just like I said, it's easy to play the blame game. And, that's why I'm glad we're having this talk. And unfortunately, we've been guilty of it. I can't cast a stone. You get tired, you get anxious, and the patients are coming to you because they see you 5 days a week in radiation. They might get chemo once every 3 weeks. So they're going to come to you because you're sitting there with, it's a chemo issue. Have I been busy and guilty? And be like, call your med-onc? Yes. Have I done it? Yes. Am I better at it now? Absolutely. Because, I need to be, and there's always time. We always got to never forget that these are patients, and you could have told them yesterday. It doesn't matter. That little extra time, 5 minutes, 10 minutes to either help them facilitate, because usually what they'll say is, I've been calling, I just haven't gotten a call back, and that's where you really kind of need to stop and take that patient aside and really kind of get that problem situated, and I think making this a team effort is what we need to do. And again, this is something that's been in the works since we existed. I don't like it to be us against them, because it shouldn't be. But that's the whole point of concurrent therapies. We work better together.
Absolutely. Well said. Thank you so much, John, for your time today.
Thank you, Jaime.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.